Welcome back to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derick Davis, a physician in pain and PM&R. Today we're tackling running injuries and REDS, where biomechanics, training load, and fueling intersect with mental health and performance, plus what actually helps. I want to briefly introduce my incredible and brilliant guests, starting first with Sara Kellahan, who is a nurse practitioner at the WashU Living Well Center. She practices lifestyle medicine for MSK pain, obesity, nicotine addiction, and other chronic conditions. Next, we have Dr. Elena Randazzo, who completed her PM&R residency at Ohio State and a sports medicine fellowship at WashU after medical school at Mizzou. She specializes in nonoperative MSK care with a special focus on female athletes and performing artists. And lastly, we have Dr. Katherine Caldwell. She is a former D1 swimmer with an MD from Mizzou. She did her PM&R residency at Penn and a sports medicine fellowship at WashU. She leads the WashU Female Athlete Program. In this episode, we hit early warning signs for injuries, myths related to running shoes, strength and cross-training that actually reduce injuries, and how to protect long-term bone health and performance. So let's get into it. I hope you learned something and enjoy.
World of Pain and PM&R podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information in this website. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Thank you all for being here, first of all. I really appreciate everyone's time.
We're happy to be here. Thank you. Thanks for having us.
Glad to be here.
Awesome. So first of all, I just wanted to kind of go around and ask how everyone got interested in your respective fields.
Yeah, I'm happy to start. So I'm Katherine Caldwell. I'm a sports medicine physiatrist here at WashU, but as I think most of us in sports medicine, I have a background in sports, which is what kind of led me to this. So I was a competitive swimmer growing up. I swam for Texas A&M in undergrad. So I was a D1 athlete. I had qualified for Olympic trials, so I'm very aware of kind of the, mindset when it comes to dealing with elite athletes. So I think I kind of naturally fell into this path. So I always knew that I wanted to kind of move forward with sports medicine and treat athletes, but also specifically focus on female athletes and be able to counsel patients about things like, recovery and nutrition and kind of more than what typically we think of as, just traditional like orthopedic sports medicine.
Excellent. Awesome. Sara, how about yourself?
Yeah, so I'm coming at this from a little bit different angle I work in a lifestyle medicine clinic at WashU. So within WashU Orthopedics, we have this lifestyle medicine program for patients with any type of musculoskeletal issue. And so we think about how nutrition and movement and stress support and sleep and social connectivity, all these things really impact your health and functionality. And so I see a really wide variety of patients. I came to this after working actually more on the chronic pain side. So I was in rheumatology at WashU. Before that, I worked in a multidisciplinary program at Vanderbilt that was actually for high-risk HIV patients. And so in that role, I was able to see kind of more of this multidisciplinary holistic support really helping patients. And so then working in the chronic pain realm with rheumatology, a lot of autoimmune diseases, fibromyalgia, I found there's such this need for more of that. And so that brought me over to the Living Well Center where we do this more holistic approach to things. From this model, though, and working with lifestyle medicine, not only does it serve that population well, there's such a need for our younger populations and our young female athletes who are, their bodies are changing. There's so much going on and there's so much misinformation out there as well. And so I've been really excited to kind of join in with the team and think about how, supporting people from a younger age with the ways they nourish their body and move their body and think about their mental health and that mind-body connection, how they're sleeping, their social connections really impacts their health, their performance, and even as they transition in and out of sport throughout their life. What does that look like? How do they kind of process those changes?
That's amazing. Yeah, I think that's so necessary these days. I just did a podcast on pain psychology. And again, I think in the United States, we look at pain and we look at the body as very mechanically, like as if you were to take it to an auto shop or something like that. And I think coming up from a holistic perspective is amazing, exactly what we need these days. Dr. Randazzo, how about yourself?
Yeah, so I'm Elena Randazzo. Similar to Dr. Caldwell, I have a history in sport, which kind of led my passion for my current practice. So growing up, I was actually a figure skating athlete, did that for 14 years through high school. And then once I retired from figure skating, I started to pick up additional exercise and kind of health classes. So love to run, love to take cardio classes, really anything fun. I would love to try it. And I still kind of lean towards that today. So I love to be active for kind of my overall health and my mental health. And then in terms of why I liked PM&R in sports medicine, so similar to a lot of folks who go into PM&R, I loved the focus on function and getting people back to doing what they love to do or finding a new normal for them. So that really inspired my path through PM&R. And then specifically going into sports medicine, I really resonated with the athletes given my history as an athlete as well. And while I was in residency, I felt like I was really seeking out opportunities to treat female athletes or to learn more about them, but I actually didn't feel like that structure was built into my residency program. And I don't think it's built into a lot of residency programs across the country. So it's really what sparked my interest in it at that time. And, the more we read about it, the more we realize that our research is, kind of behind on female athletes. But we'll be talking today about relative energy deficiency in sport. And it's, they're complex medical conditions that can be specific to, it can happen in males as well, but specific to female athletes and have a long-term sequelae. So I think that's what really inspired my passion for it, is that we've got to, close that gap in research. We've got to get this information out to our young athletes and make sure that we are a resource to them so that they don't kind of end up in long-term trouble.
That's wonderful. Well, you three are the best for this podcast, so I'm excited to get started. Today, we're talking about sort of injuries or pain in runners, and then also REDS, like you had mentioned. So just kicking things off, what are some of the most common types of pain or injury you see in runners?
Yeah, so for our running athletes, far and away, the most common injury that we're going to see is going to be in the knee joint. So up to 31% of all runners will experience a knee injury during their career, and it's even higher in our female athletes. So we see that can be up to even 40%. The most common thing that we see, especially in our female athletes, is patellofemoral pain syndrome. That's also called runner's knee. Other things we might see are focused on the knee joint itself. So we might see flares of osteoarthritis. Someone may have an underlying meniscal injury that flares up and causes them pain. Another common thing would be like patellar tendinopathy, so an overuse injury to that patellar tendon. We see that more in our adult population, and in our younger folks who still have open growth plates, we actually see what's called Osgood-Schlatter or an apophysitis. And so it has a little bit of a different name if you're a young athlete and a little bit of a different pathology. And then IT band syndrome can be common as well. And then after knee injuries, we tend to see foot and ankle injuries be pretty common. So Achilles tendinopathy, other Achilles injuries. In the foot, we can see plantar fasciitis, stress fractures. And then we do also see bone stress injuries in the shins as well, or the tibia, which I think we're going to be talking about more as well.
Do you divide that in your mind of how patients present? Like, oh, it's an overuse injury. Oh, it's a stress injury. Or is there a sort of framework in your mind that you use to sort of divide these when you see a patient in clinic?
I would say I definitely do. For the examples that you gave, so a bone stress injury or like a tendinitis or a tendinopathy, those tend to fall more into the chronic overuse category, but we definitely see some acute injuries as well. So we'd see ligamentous injuries, meniscal tears. I would say those can kind of fall into the more acute injury, or if they've had an accident or trauma, we can see more acute injuries as well.
And things that often come up when you talk to runners or when you go to running clinic are things like you had said, the runner's knee and shin splints and stress fractures. How do those present, and what's the difference between all of those?
Yeah, so for runner's knee, that is patellofemoral pain syndrome, which I had mentioned before is very, very common in our running population. So that tends to present as pain kind of in and around the area of the kneecap or the patella. So they can feel discomfort with both running activities, and they oftentimes can have pain even at rest. So sitting with their knees bent can be like quite uncomfortable for them as well. And it's caused by a couple of factors. So one of the big ones we see for that is that the patella is actually not running smoothly within its track. So there can be a little bit of malalignment with where that kneecap is sitting. There can be muscular imbalances or poor running biomechanics that can all work together to cause that pain. Shin splints is also called medial tibial stress syndrome. So that's kind of pain in the shin that people experience, runners experience. That can sometimes feel a little bit better when you start to run, but as the run goes on and then after runs, it can be more painful. And really, shin splints are an early bone stress injury. So those are on that spectrum of bone stress injuries that can end with the completed stress fracture of the tibia. And so that is considered an overuse injury as well. And then just for a little bit of basics on what a bone stress injury is, it's really that there's a mismatch between the amount of load through that bone and then the amount of recovery that you're getting. So you're really kind of causing micro trauma, micro damage, because you're putting too much load through that bone and you're not allowing the bone enough time to recover. So that can happen oftentimes if people are increasing their running regimen too quickly. So either distance, time, or speed a little bit too rapidly, and then not really allowing their body to recover. Or just kind of chronically running higher mileage, like greater than 20 miles a week or so, you start to become at risk for these types of injuries.
So those runners that run more than 20 miles a week, is it just because they gradually built up to that, do you think, is why they're able to avoid these sort of things?
Yeah, I think gradually getting up to that point is very important, and then making sure that they are getting adequate rest, adequate nutrition, and some of those other factors that can also contribute to your recovery. And we'll talk a little bit more about that too. Like sleep is really important, making sure you have rest days. You can have active recovery days. So just making sure you're giving your body that time to recover between training sessions.
Got it. And then, so poor running mechanics, does that factor into how all these things come about?
Yeah, I can take this. So, yeah, absolutely. So when we're thinking about, poor running mechanics, obviously intuitively, poor mechanics equals a higher risk of injury. So, some kind of common things that we see are, one is weakness in the hip abductors. So the muscles that kind of stabilize your pelvis. What we'll see that as kind of clinically is if you do a running gait assessment, the runner's knees will actually kind of cave in as they're running and loading that leg because their hip isn't strong enough to stabilize. So that's something we call, proximal control. So we know that when the core is strong, the hips are strong, kind of keeps everything downstream in alignment. So we're really looking at the mechanics of what is your hip doing, what's your knee doing, what's your ankle doing. And if any of those are off, it's going to throw off everything else. The other thing that's really specific to running is stride length. So we know that a longer stride length with running actually increases your injury risk. So what's more helpful for runners is to kind of shorten that stride length a little bit, which then will increase your cadence, right? So kind of how quickly you're going through your cycle. And that can definitely help with reducing injury risk. The other main thing too that we look at is what's your foot doing as you're running. So a lot of people will overpronate, which basically means your foot's going to sort of cave in and flatten down. When that happens, your ankle's obviously kind of rolling through to the inside, which drastically increases risk of things like bone stress injuries, as well as like tendon issues like tendonitis or even like tears. So certainly running biomechanics is really important. Often for my patients who either are running really long in terms of mileage, or if they're coming back from an injury, I'll have them go to one of our physical therapists who we partner with who can do like a formal running gait analysis to kind of figure that out before we let them increase back to that, 20 miles or whatever they're wanting to do.
This running analysis, is this done on a treadmill? Is this like with or you're videoing it, or is it done outside, or how do they do that exactly?
Yeah, good question. It's actually a little bit different based on where you're at and what equipment they have available. So more often than not, it's done on a treadmill and they will video it. The benefit of videoing it is because obviously you can slow it down.
Yeah.
So when you're looking at something in that slow motion, you can really take a look at, okay, what are the hips doing? What are the knees doing? What are the ankles doing? And kind of really parse out what is happening. Versus obviously when you're just kind of visually looking at someone run, sometimes it's happening a little bit too fast and it's hard to pick up all those kind of subtleties. So yeah, certainly video analysis. If patients are able to get outside and go through a run and gait analysis with a therapist or whomever, that's actually really nice because sometimes people will alter how they're running based on surface. So if you're not typically running on a treadmill and then all of a sudden we ask you to get on a treadmill and then video how you're running, that can change things a little bit. So in the most ideal sort of scenario, yeah, running outside or kind of on your typical surface would be the best. But not everybody has that capability. So I would say the most common definitely would be on that treadmill.
Do patients, runners, do they bring their shoes in and ask, this is a minimalist shoe. This is what I want to run in. This is one that has heavy cushioning like the Brook shoes or carbon plated ones. Do they bring them in? And what's your conversation like when discussing, using some sort of different type of footwear in preventing or causing injuries?
Yeah, absolutely. So this is a question that we get all the time. So interestingly, if you look at the actual literature that's out there, there's no conclusive evidence that changing the type of shoe wear drastically changes your risk of injury. But this is kind of looking at the general population, right? So we already talked about there are certain kind of injury patterns related to biomechanics that can pop up. So if you have someone who, overpronates, their foot kind of rolls in when they're running, if you get a shoe that has better control from that standpoint, so it's not allowing that foot to cave in, then that will reduce their risk of injury. Unfortunately, though, the data looking at everything just looks at general population injury risk and doesn't really look into, the specifics into how the person's running. So that's why it's really individualized person to person. So we get questions all the time in terms of like, oh, do you recommend, higher, lower heel drop or minimalist or more cushioning or whatever? It really is so individual that it's hard to answer from a general standpoint. So I really don't answer that until I actually evaluate the patient in clinic and kind of see how they're moving. Generally speaking, though, intuitively, the minimalist shoes don't have a lot of cushioning, right? So if you're worried about somebody who's running long distances and we're worried about something like stress fractures or bone stress injuries, that's not going to provide that kind of protection from the ground. So that isn't really something that I tend to recommend. I do like the shoes that have a little more structure, a little more support, a little more cushion. But when we get into those shoes that are really super soft and cushy, that can also increase injury risk because now your foot's kind of collapsing because it's so cushioned. So there's kind of a balance in there. And I think it's best to kind of look specifically at the person and then evaluate based on that. The other thing that's really helpful to look at actually is if a patient does bring their own shoe into clinic, you can look at the tread pattern on the bottom of the shoe. So kind of where that shoe is worn down to see like, oh, is it solely worn down on the outside of the shoe, meaning that you're constantly putting pressure through that part of your foot. And if that's the case, we probably need to change your shoe wear because we don't want you running on just the outside of your foot, right? So there are a lot of factors that go into that.
Good to know that you don't necessarily predispose yourself to worse injury just by switching to one of these different types, just because I have enormously wide feet and I prefer the higher cushion. So at one point in time, I was thinking that I would get those like, 5-finger, are they called 5-finger or 5-toe? I don't know.
I know what you're talking about.
Yeah, I was going to get those, but then I was like worried about, getting these stress fractures or these the shin splints and everything like that. But I should have tried it out. Is there a certain, Dr. Randazzo kind of already mentioned this, but is there a certain volume or intensity that you warn runners of or that predisposes them to an increased risk of injury?
Yeah, I can take this one. So, we have runners that run all different lengths and distances and intensities. And some are running at high levels and aren't getting injured. And some are running at lower levels and getting injured. But we know that in general, once you're passing that 40-mile-a-week mark, that does predispose you to a higher risk of injury. And, one of the things that is important to note is most of the studies on this are done in men. And so it is unclear for women, is that the same? What's different? How do we think about that? When they look in general at the research in general, that increase in training, especially if you're increasing that intensity, whether it's distance, speed, whatever that looks like, there is just that higher risk. And so there is a discussion. One of the things that often gets recommended is a 10% rule. So you don't increase your training volume or load by more than 10% per week. It's unclear if that's, the magic number. That's kind of generally what the consensus is. But we know in general, it makes sense, right? That if you're going to increase intensity, volume, length, try to do that gradually. One thing, and we'll talk about this, I think, a little bit later, but when it comes to cross training and thinking about that full body care of yourself, which I think we talk a lot about cross training, we talk less about the sleep piece, the nutrition piece, all those things I think really play into this well. Taking care of the whole person, we know in theory is going to help prevent those injuries too with that increase.
And are there running signs, or warning signs for runners that they should pay attention to before these pains become a bigger issue or a long-term issue?
Yeah, absolutely. So, kind of a general rule of thumb is if something is hurting and you take a little bit of rest, you maybe use some ice, whatever, and it's not getting any better, that's a reason to think about getting it checked out. We've talked about all the different types of injury patterns that can happen in runners, whether it is, an Achilles tendon thing or a ligament thing or plantar fasciitis or, bone stress injury. All of those things present really differently. So it's hard to kind of give a good kind of general rule of thumb. But I tell my patients, if you are consistently trying to push through something that's hurting you and it's that same pain every time, and say you're starting to have to, take ibuprofen before you go for your run, those are all signs that something is going on and you really should get it checked out. It's much, much easier from our standpoint as well as the patient standpoint to treat these things on the earlier side of the spectrum rather than later. So if I can treat something when it's still, a bone stress injury, meaning some swelling in the bone, rather than the point at which it's progressed to a full-on stress fracture, that's a much easier thing to treat rather than now we're dealing with this chronic thing because you kept pushing through it. So I basically just tell my runners and all of my athletes really that if you're consistently trying to push through something, that means you need to take a step back and get it checked out. Worst case is that you take a couple days off from running, we do some evaluation, we find out it's okay, we can get you back into it. Awesome. But we want to know what's going on.
Are stress fractures sneaky? Do they come up and you're just like, oh, I didn't even realize there's this stress fracture? Or how do they present typically?
Yeah, great question. So more often than not, we're talking about tibial bone stress injuries, so in the shin bone, which often, like Elena was saying, gets confused for shin splints. So I see patients almost every single day who say oh yeah, I've had shin splints for 2 years. Well, you don't have shin splints for 2 years. That's not how shin splints kind of behave. So at that point, you're like, yeah, that's probably a stress fracture, right? But a lot of runners have been told that shin splints are so normal with running, and that's why they're sneaky, because they're like, oh, well, everybody has shin pain when they run. That's normal. But it's not. The other thing that I see really often in runners is stress fractures in the feet, which makes intuitive sense, right? Because you're kind of constantly pounding on your feet. I have lots of patients who come in who are just like, I don't know, my foot has kind of hurt for the last 6 months, which that's a long time. And stress fractures compared with an acute traumatic fracture, it's not like all of a sudden, oh my gosh, that hurts so bad. It's just kind of this chronic nagging thing that pops up. So yeah, they can be super sneaky. When it comes to the bone stress injuries or stress fractures in the foot, what I generally tell people is that if it's a more kind of generalized muscular sort of feeling soreness, that's one thing, right? Because people get sore when they run. But if it's more of a localized pinpoint thing, that's more indicative of a stress fracture. And especially if you have swelling or bruising associated, that is probably a stress fracture.
So when it comes to treating some of the things that Dr. Randazzo was talking about, like knee pain, there's a mantra, I feel like, in medical school, and especially in PM&R, is to not use at least back bracing. I've looked into the data of this. I don't think it's heavily supported, frankly. But I do get the idea. I mean, if you have a cast on, you're going to have some atrophy of your muscles. You're going to have some loss of range of motion. And it's very important that we maintain range of motion. And then, can bracing get in the way of this? But things that we don't talk about as much, I think, at least in the medical community, is doing things like knee braces or knee sleeves. We use them kind of instinctually, I think. What's your conversation around knee sleeves and knee braces for knee pain?
I think there's definitely a role for bracing. I would say if you are an athlete, sometimes we have athletes that may pick something up at the pharmacy and already have it before they come in to see us. Right. So I would say if you're an athlete and you're considering getting a knee sleeve or a knee brace or something off the shelf, you're probably at the point where you warrant a medical evaluation. And I say that because we do have braces for specific purposes and for different types of knee pain. So I think it's really important that we get you fit in something correct for you that matches the pathology that's going on. So some examples might be for folks who have arthritis and that's causing pain in their knee. There are some people who feel a little bit better with some compressive support with something like a knee sleeve. They can still function pretty easily in that type of brace, and it helps them to get through their activities a little bit more easily. There are, of course, bulkier braces that we can offer for arthritis. Those aren't tolerated quite as well. So, we can always try starting with something a little bit low profile and seeing how they do. Whereas if it's from the patellofemoral pain syndrome that we've talked about, where that kneecap isn't in its appropriate alignment, something more like a patellar stabilizing brace might be something that we would try for that specific pathology. Or a patellar tendinopathy, which is so common, we would maybe refer them to a trial of a patellar tendon strap. And so I think if they're just having generalized knee pain and they're considering trying something, they should come to see us just so that we can make a diagnosis and then fit them for something that's appropriate for what's going on.
Does anyone ever ask you about those knee sleeves that have a copper in them, I think it is? Has anyone brought that up?
Yeah. All the time.
Okay, all right. Yeah, I didn't know that. Like, there's kind of a big market for different types of knee sleeves and everything. Mm-hmm. And if you look on Amazon, there's like tons. So
yeah, they have really good marketing.
Yeah.
Not so good data. But that being said, if patients like them and they think that they help, I have nothing against it. Mm-hmm. So even if something has kind of meh data, if patients are doing well with it, like go for it, right? Because it's not hurting anything. And the other type of bracing too that I talk to patients about a lot is actually for the ankle. So we get a lot of patients who, maybe they've had like an Achilles thing or some tendonitis, or maybe they've had like an ankle sprain. A typical brace that we recommend for that is called an ASO, or an ankle stabilizing orthosis, which those are nice because they fit into a typical kind of running shoe, right? And that can be helpful for actually preventing recurrent injury, especially after something like an ankle sprain where your ankle is inherently less stable than it was before. I certainly have people pair that with appropriate physical therapy to restabilize the ankle. But, kind of to your point of, people they tend to be like, oh, we shouldn't use bracing because it'll cause, weakness or atrophy or whatever. That's certainly not always the case and can actually prevent recurrent injury in a lot of cases. So I think that in particular in our athletes or runners, they can be helpful. Mm-hmm. I don't know that people need to use them 24/7, but if you're in your sport and they're helpful and they're helping you kind of get through your sport and also prevent another type of injury, then why not?
There's something to be said about the proprioceptive feedback that you can get from braces and sleeves that I think, even when people use those belts for doing squats, I think there's something to be said, but I know it increases kind of the intra-abdominal pressure. But speaking of squats, what about strength training and doing cross training? Are those things that you recommend? Do they actually help with preventing runners' injuries?
Yeah, absolutely. I would say that cross training is probably one of the kind of top topics that I talk about with my patients. So we see a lot of patients who do this kind of activity that is in one plane, right? So like running, your legs are constantly going forward and backward. Same with cycling. And if you aren't cross training and exercising in kind of the opposite direction, then you're going to have weakness in those muscles. So, I already alluded to, we kind of see this pattern where runners will have weakness in their hip abductors. So gluteal muscles on that side of the hips that then causes that weakness, allows the hips to cave in, which then causes a whole bunch of issues in the lower extremities. So that's really super important. The other thing we know is that when it comes to things like bone stress injuries, if you don't strengthen the muscles around those bones, you're just going to continually increase your risk of re-injuring those bones. So if you just let someone, rest and then go straight back to running, well, now they're deconditioned and their muscles are weak and they're not able to really take that load and disperse it. So cross training is really super important for those athletes as well. There was actually a really great paper that came out back in, I think, 2024, so not that long ago, that looked at patients who did this kind of cross-training protocol where they did strengthening exercises both for their hips as well as for their core. And they actually saw greater than like a 30% reduction in lower extremity injuries. And they also saw, I think it was like over a 50% reduction in kind of all-cause overuse injuries, which is really substantial.
Are there certain exercises you give specific to sort of working gluteal muscles or leg abductors, hip abductors?
Yeah. So I have some printouts that I generally use in clinic to give to patients, which those typically I will use either if the patient can't get to physical therapy or it's going to be a while till they can get in or whatever, because ideally I would want them evaluated by a physical therapist and get kind of an individualized protocol. But I do give people these handouts that have some exercises specifically for the core as well as the hips. So from a core standpoint, we're thinking about like planks and things like that, right? But it's not just in one direction, it's also on the sides. And then from kind of the gluteal musculature standpoint, like squats are great as long as we are continually making sure that the knees are tracking over the toes, so they're staying out, which a really good exercise for that is actually to put a band around the knees and then do the squat with that on there so that you're constantly having that feedback of, I have to push my knees out, right? So that's a really good one.
I didn't realize that's why people have the band around their knees. That's really,
yeah.
So
it's a good one. You should try it.
Yeah, knees over toes. Okay, so and that actually that doesn't look like they necessarily like the knees necessarily go directly over. Like I should still be able to see my toes when I'm looking down, or where do the knees need to be exactly?
Yeah, so you should still be able to see your toes. So when you're doing a squat like that, you're thinking about keeping your weight kind of centered over your heels and your midfoot. So definitely not into your toes. If you're feeling the weight into your toes, that means you're leaning too far forward. So weight centered in the heels, knees kind of tracking right above. You want to keep your shins essentially kind of perpendicular to the ground. So when you're looking at yourself in like a mirror, you don't want to see that your shins are kind of tipping forward. At that point, you definitely can't see your toes anymore, right?
Yeah.
So that's kind of the alignment that we want.
That's great to know. One time I was interviewing for, one of my interviews for residency, they asked me to explain something. And I chose to explain how to do a squat, and I did such a poor job of it. You did a much better job.
That's actually so hilarious. I did the exact same thing. I don't remember which like residency program it was, but there was definitely some place that asked me to explain something, and I was like, "Great, we're gonna squat."
Yeah, oh, okay. And you probably really nailed that question where I didn't get it. And,
I was also a kinesiology major in undergrad, so I feel like that's cheating a little bit.
Yeah, that probably. Yeah, I was biology and Italian, and so I didn't have any of that. But speaking of exercises, with stretches could probably be a podcast in and of itself, but are there certain stretches or mobility drills or warm-ups that you recommend or that actually make a real difference when you're trying to prevent injuries to runners?
Yeah. So, actually there's not a clear, this is the way to do it. When we come to this, which as we find with a lot of different things, but I think most runners, especially like I ran track and we always did, the butt kicks, the high knees, the leg swings before we got going. And we know that generally some movement does seem to help. The data is mixed on, oh, you need this much or for this long, or you need to do these specific stretches. There is data that if you are prone to soft tissue pain or low back pain, doing some sort of movement and stretching before you start running can be beneficial. Also, if you have a history of plantar fasciitis or Achilles tendonitis, there's evidence that doing some stretching and mobility work before you get going, that can really help. But once again, there's not really this is the way to do it. Where the data on injury prevention seems to point once again to that cross-training piece, that hip abductor weakness, as we've talked about a lot, and really kind of focusing on those pieces. There's not a set, this is the way that you should, even though in general, kind of warming up the body. And really, once again, it goes back to that, really listening to yourself as a runner and paying attention to your body. I think, and we talk a lot about this, I think a lot of times athletes can sometimes tune out their body because they're taught to, okay, push through, do the next thing. And so I think a part of this is that learning kind of your body and, oh, okay, I did better and I felt better on that run or in that training route by doing this, a little bit more stretching here or things like that. So I think part of it is teaching your runners to do that and listen to their body.
So would you, or is it okay to start running without stretching beforehand?
Yeah, that's a great question. I don't think we have it. I don't think you can't do that. I think if you're someone that you can get going, I think I would caution against it, especially if you're someone that tends to be stiff or if it's really cold out. If those muscles are tight or tense, I think that once again, the data is kind of mixed, but I think in general for my practice, that's going to make it more likely that you could injure something, especially if you have a history of injury. So I would recommend some sort of movement, maybe don't just pop out of bed and immediately start, running a 6-minute mile pace. I would say get some sort of movement in first. I don't know if you guys would say anything differently, Katherine and Elena, but that's what my advice would be.
Yeah, no, I agree. I think if we can get in some sort of like dynamic stretching warm up ahead of time, even if it's just like 2-3 minutes, it's helpful. If the person is like flat out, no, I'm just going to run, I'll tell them to just ease into it as best they can. But I know like for myself, like I have a history of a bunch of knee injuries and I cannot just pop right out there and start running. Like I will hurt myself. So if I do something ahead of time though, my knees feel fine. So if I can get patients to do a little bit of something, that is more helpful than nothing. But yeah, just like Sara said, there's not like a specific protocol of like, this is what we should do. I don't think it has to be overly complicated. I tell people to just kind of get out there, move around a little bit, stretch a little bit, and then get going. That's fine.
I used to really be in this mindset of stretching before every exercise and everything like that of an injury. But then I got older and I had limited amount of time. So I just stopped altogether. I don't even stretch after workouts most of the time now too, but I probably should to at least.
I know now, especially once you're a parent, you have so much less time to do anything.
Yeah.
I mean, if I'm like, okay, I have 30 minutes to work out, it's so hard to be like, okay, I'm going to take 5 minutes of that stretch. Exactly. I recently have realized that I need to reincorporate some of that a little bit more.
Yeah.
But yeah, it's hard when you're limited on time.
It truly is. Now, speaking of kind of getting the mindset of stretching and everything like that, have you seen how mental health or mindsets sort of play into pain and injury? Like you mentioned earlier about runners kind of ignoring their body and athletes ignoring their body. How have you seen this mindset play out in injuries?
Yeah. So I think that, I think that in general, in culture and in medicine, we're starting to talk a lot more about the impact of mental health and mindset. And I know that this has been talked about some in the athletic world. I remember being at a swim camp at University of Michigan years and years ago, and we did mindfulness. And I was like 9 years old. And I was like, what is this? So there's been, I was like, what is happening? I've never heard of this. What's anxiety? Wasn't back about it as much as at least around me, but I started to get exposed to it then. But I think, one thing we know is, especially for high performing athletes, there's such this pressure to perform and keep going. And I think, as I mentioned, you can ignore your body at points. And so I think that if you're not listening to cues, or if you haven't really gotten in touch with your body and different cues in your body, even with fatigue, it doesn't have to just be pain, but also fatigue and things like that, then I think you can miss things and miss injuries. And then I think there can be this distrust of yourself, of knowing, am I injured? Am I not? And I think there can be, when we feel pain, that initially there's some fear that comes up with us typically, right? It's kind of this, something's wrong. And so then I think when a runner or an athlete does experience pain, it can kind of lead to this cascade and this kind of self-sabotage and this, it can become this limiting thing of, I don't know what to do now. And then you feel a little bit of pain and you don't know what to do. It's kind of all one big thing. And so I think really helping both athletes be in touch with their body and kind of understand things, knowing how to be kind to your body. But then also knowing, okay, this is a little bit of soreness. What does my body need in this, right? Maybe it is something that I can keep going a little bit. Or maybe this is a warning sign and I need to pay attention to that. So I think really kind of helping and supporting athletes with that is so important, helping them understand their body and the different things going on with that. I also think that it's easy to use sport to suppress other things that have happened in our past. So if we have a history of trauma, if we have a history of hard things happening, I think it's easy to utilize. One of the ways that you can cope with that is through intensive exercise and sport. And so I think that it's really important when we're working with athletes to get to know them and know everything going on in their lives and what's actually driving them. And is there places where, they could use some additional care or additional support if that's something that's driving them? Because at some point they're going to hit a hard stop with that, where it's not going to get them or really meet their actual need. Like actually that training or risk for overtraining isn't actually meeting the need of that past pain. And so actually it's going to help them be a better athlete. It's going to help them in life if you can think about their whole person care and what else they may be needing.
Those are really good insights. I didn't really think about that as using sport as an outlet, but I mean, obviously it makes sense. When do you reach out to your maybe colleagues in psychology to get them involved, or do you kind of bridge that gap yourself and try to help deal with that psychological element?
Yeah. I think I try to, with each of my patients, just to kind of be curious about all the different parts of their life, kind of how things are going. If someone is maybe feeling really good in sport, but really struggling in other parts of their life, I think that's something to be curious about. You're having a hard time with friendships, but sport's the one thing. How do we kind of dig into that and what's kind of going on? And I think at that, in those questions, I'm very quick to say, I think there's great benefit in meeting with a mental health therapist and getting more support in that way. I remember years ago, I was talking to a colleague and they asked me what I was doing later that day. And I said, I have some marriage therapy. And they said, what's wrong? Oh no, your marriage. And I was like, oh, nothing's wrong. It's just, it's like go to your primary care. You go in and check in. And it can be helpful to continue that healthy marriage by having those check-ins. I think I try to bring up mental health therapy in that way of, it can be helpful to have a check-in. You don't have to go all the time. Sometimes you realize, I want to go a little bit more, but I'm very quick to say, hey, this is a great support if you want to engage it. So I try to start that conversation and make them aware of it, even if there's not any flags initially, just so they know there is that. Because at some point, everyone to some degree probably has something that could use some further processing or support or engagement with. And so I always try to keep that door open for them. And then if there's something where I'm really concerned, I do just say, hey, I'd really like us to consider getting you some more support in this area.
Yeah, that's wonderful. I think we should talk more about that. It's funny how, like you said, when you were 9 years old, talked about mindfulness and anxiety and how those things were very, I guess, unique for that time. Now we're talking about them more, but yet I still think there's a stigma associated with seeking out mental health providers, therapists. And I think that the brain is just so complex and it's more complex than the knee. And yet we neglect it more than the knee oftentimes. And I think that, those tune-ups, those visits with a therapist, those visits with a psychologist or healthcare provider, whoever it may be, is so important. But there's so many barriers to care at this point for it. I could go on forever about that, but what's one piece of advice that you wish every runner knew about in avoiding injury or managing injuries?
So my piece of advice would be, and I think we've harped on this a little bit so far in our talk today, but just don't let acute injuries become chronic problems. So please try not to ignore your body. If your body is telling you something, if you're having pain in the ways that we've discussed that's kind of persisting despite rest, or that you're needing medication for, that you're concerned about, just go get checked out, because if the longer you let things kind of go on and fester, the longer it may take to recover, or could become more of a chronic problem for you.
Yeah, that's a great piece of advice. It's sad nowadays that life seems like it's moving so fast that you don't have time to just go get checked out. You should just go checked out if you have some sort of concern to prevent the bridge from acute to chronic injuries. I want to switch gears here real quickly and go from these runners' injuries and pain to what's called REDS. I won't sort of fake describing that I know much about it. So I wanted to know exactly what is REDS, and it transitioned from an older concept of what was called the female athlete triad.
Yeah, you're 100% right. So REDS stands for Relative Energy Deficiency in Sport, and it is really an expansion on a former diagnosis we call the female athlete triad. So at their core, they're caused by low energy availability. And so what is low energy availability? I guess first, let me talk about energy availability, then we'll talk about what makes it low. So our energy availability is the leftover energy we have from our diet, from our nutrition caloric intake, that our body uses to kind of optimize all of our body systems and helps them to function. And it's what we have left over after we exercise. So when we have low energy availability, there's really a mismatch between how much we're consuming and taking in, and then how much energy we're spending with our exercise activity. And we simply don't have enough energy left over to help optimize our other body functions. So that could be certain organ systems, it can be the way we perform in sport. So having that prolonged low energy is what causes relative energy deficiency in sport, shortened to REDS, and what we know caused the female triad, which is kind of a narrowed in portion of REDS. So the female athlete triad historically was a combination of that low energy availability, menstrual dysregulation, so having irregular periods, not delayed menarche or delayed first period, or even amenorrhea, so not having your period for 3 months or more, and low bone mineral density. So that's what made up the triad. And then in 2014, there was an International Olympic Committee consensus statement that came out that defined REDS, which is really an expansion on that diagnosis. So we now understand that low energy availability can also impact our immune system, our metabolism, how we synthesize glycogen, our cardiovascular system, our hematological system. And in turn, all of those things can have an overall impact on our well-being, our injury risk, and kind of our performance overall in our sport.
What are some signs or symptoms that someone might be dealing with this themselves?
Yeah. So I know we already talked about stress fractures a good bit. That's one of the that's a common sign, right? Having a stress fracture, having leg pain, maybe it's, I've had shin splints for 2 years. So things like that. Abnormal periods are one. Now I will say on that too, you could be having normal periods, but not ovulating. Now that's not going to be something that probably a younger athlete is going to pay attention to. But if you're moving into childbearing years, that could be something where maybe they're under fueling, they're still having regular periods, but they may not be ovulating if there's that lack of fueling. So that's something, but those, I think young girls, abnormal periods, it might be like, I haven't had a period. That's kind of nice. But actually, that's a sign of something bigger going on, and can have a big health issue. Lower energy, decreased performance, mood changes can be another one. Weight loss is one, but it's not necessarily there. You can even also, I think something important to note is someone may still have a normal or even a little bit higher BMI, but they've lost weight, or maybe their weight's not changing a lot. That doesn't mean this couldn't be happening. The body could be compensating and keeping that BMI up. Even while this is happening with that low energy availability. And just in general, eating disorder signs are something to look at. So either avoiding food, or even sometimes a hyper fixation on baking, cooking, but not necessarily eating it. not eating around family. If they're not having family meals, this can often go missed, which happens in busy families, right? You're not sitting down together, so you may not notice someone's under fueling. In general, if they're reading a lot of labels, paying attention to, if there's an overfixation on calories or macros, or they're talking a lot about nutrition, I think it's a place for parents, coaches, people just to be curious about and, to keep tabs on it, pay attention to things there. And then I think also, signs like someone's going to the bathroom after every meal right away, things like that could indicate something bigger, like a binging disorder or something like that. There could be some other signs.
Yeah. The other thing too, that I want to add, just because Sarah mentioned like family meals. One thing that I do commonly see with my adolescent patients is that they are eating with their families, and maybe mom and dad are following like a low carb diet because they're trying to lose weight. And then the kid is eating what mom and dad are eating, which makes sense, right? But then, it turns out for dinner, maybe they're eating like a chicken breast and some steamed broccoli. For someone who's not athletic, maybe that's enough, maybe not. But for someone who just did like a 2-hour practice, that definitely is not enough. So they're not consuming enough carbohydrates or fats to kind of fuel themselves. So those family meals too can sometimes kind of play into this. And so it's also important to figure out, what's the rest of the family eating.
And because of the nature of your specialties, you will likely see more reds, but I'm just curious, is this a pretty prevalent thing, or how much is this going on in society?
Yeah, I'm happy to take this. Really good question. The answer is we don't know. So, first of all, the IOC didn't come out with this definition of reds until 2014. So it's not like it's been around for forever, which means that the data out there is still a little bit sparse, although it is becoming better. The other thing too, when we're trying to figure out how prevalent is this, the unfortunate thing is that we know that a lot of times this is going undiagnosed. So a lot of times, actually, when I see patients with reds, they've had it for years and years and no one has picked it up. And if those are the ones that just are happening to show up in my clinic, like how many out there just go completely undiagnosed, right? Because, like Elena was saying, with reds, the signs and symptoms are so diverse. There are lots of different things affecting a lot of different body systems, excuse me. So patients often don't put those things together, and sometimes neither do their parents or their coaches or their providers. So the true answer is we don't know. The studies that have tried to look at it, the range is anywhere from like 20 to 80% of female athletes are at risk for low energy availability, which is what causes reds. That's a pretty wide range, and it is a little bit sport specific. So we know that patients who are at higher risk are in sports that either like emphasize weight. So think about like wrestling, where you have to weigh in and make a weight class, or the kind of quote unquote aesthetic sports. So like gymnastics, dancing, figure skating, swimming, those types of sports. Those athletes are at higher risk of that low energy availability. So in summary, we don't know, but it is super prevalent.
Yeah, that's really good that's why it's really good to get this out there, to talk more about this. Something, with an acronym is always sometimes a little bit hard to know what it is. In medicine, we are so notorious for 3 or 4 letter acronyms, and it's like, well, okay. And then you read like clinic notes, you're like, I have no idea what half of this means.
Mm-hmm.
So can reds affect your long-term health, or is this just acute? I think Dr. Randazzo was already kind of mentioning this, but can this actually affect your long-term health, not just current signs, symptoms of what's going on, like feeling tired?
Yeah, absolutely. So a couple of areas we know for sure can affect long-term health. So one is when we're thinking about our bone health. So as we were talking about, this low energy availability leading to reds can cause reductions in bone density, which the reason that's important is because this is super common in like adolescent and kind of, those younger individuals. We know that we gain our kind of peak bone mass by the time we're in our early 20s. And if you're already starting out at a lower bone density, then when you reach adulthood and then you're starting to lose bone mass, because that's a natural part of aging, then you're already starting at a lower number. You're really quick to get to osteoporosis, right? And that's really important because then with osteoporosis, we see lots of lots of fractures because of that. And that actually has its own risks for like morbidity and mortality, right? So bone density is a really big one we know can affect long term, even once we kind of reverse that energy availability. The other thing we know it can affect is fertility. So, there are patients who haven't had periods for a long time, or maybe, like Sarah was mentioning, just haven't been ovulating for a long time, even if they are having periods. They may not be able to conceive a child because of that. And again, this is even after we've reversed that low energy availability. Some women still struggle with fertility. There was a really interesting paper. I think it just came out in, June, so really recently, by Margie Davenport's lab, which is phenomenal if you haven't read any of her stuff. But she does a lot of research on exercise and pregnancy, and they published a paper that showed that there's actually a correlation with a history of REDS and preterm labor. So even in women who had treated REDS and their energy availability was restored and they were kind of quote unquote, back to normal, later on, there were actually adverse effects on their actual labor and delivery.
Wow. Those are pretty scary things. I think it's good that we're talking about this because this is like good information to have out there in general. Do you find that patients are pretty aware of this condition? Most of the patients you all see? Just kind of...
No.
Yeah.
Hardly anybody is aware. And, part of that too is a lot of healthcare providers aren't even aware this is a thing that exists. Yeah. Right. So, if your doctor doesn't know what's out there, how would you know what's out there? Yeah. So, no, we're trying to change that as best we can. No. But, it's hard to get good information out there.
Right. Absolutely. Now, we were mentioning things like maybe just having some broccoli and chicken for dinner. Are there general guidelines to nutrition for adolescent female athletes that you give regarding REDS?
Yeah. So, and again, this is general. So every new nutrition plan should be individualized. For the vast majority of athletes, we know that kind of generally speaking, caloric intake should be somewhere between like 2,000 to 4,000 calories. And again, super general. But the only reason I throw out that number is because a lot of especially female athletes have this like 1,200 calorie number stuck in their head for whatever reason. I hear that a lot, where they think that that's the goal. And we know that that is really super low. Mm-hmm. So the kind of general guidelines for our athletes is 3 full meals a day plus 2 snacks is kind of our goal. There actually is a really good resource, and I have these printed out in clinic and I hand them out to almost all of my patients. They're called Athlete's Plate. It's something you can Google and find online. The USOPC has it on their website too, where they have it broken down into like easy, medium, and hard training days. So I like to show that to athletes because it shows the composition of what should be on their plate. So like sources of healthy fats and, whole grains, carbohydrates, fruits, as well as proteins. And what I always point out to everybody is that when we're moving from that easy to medium to hard training, the things that are changing are the carbohydrates and the fats, not the proteins, right? So every athlete out there is like, I need more protein. I need more protein. And they're chugging these protein shakes. Mm-hmm. Most of them don't even need it. They're just really deficient in carbs. Mm-hmm. So that's something that I talk to almost every single patient about when we're chatting about nutrition, is because that's a really common misconception. So those are kind of very generally what I tell people in terms of nutritional intake. If it is a patient who I suspect REDS, they are being sent to a registered dietitian so that they can do a much more in-depth kind of treatment plan with them.
That's excellent. We have become very protein-centric and focused in the United States. And I'm 35, which is sad because I'm already past that peak bone age that you said. But when I was in the 90s, because I remember those days before 2000s, there was a big focus on fats. And then it seemed like it was carbohydrates. And now, rather than the absence of things like that and trying to omit them, it's like this big protein focus that we're all so obsessed with. And there's protein in everything. And just because you can't put protein in something, I don't think means you should. But, kind of what you were mentioning earlier about practitioners not being aware of REDS. What role do coaches, trainers, healthcare providers, even such as myself, though I doubt I'll be seeing young female athletes in my clinic, or probably I should not be. I mean, they probably should not have made it to that level of seeing, pain and spine providers at that point. But what role do these outside healthcare practitioners play in diagnosing and preventing REDS?
Yeah, that's a great question. The people who are going to be interacting with athletes most frequently are parents, coaches, athletic trainers. In the most ideal world, it would be nice for all coaches and athletic trainers to at least have a little bit of understanding in terms of what should good nutrition look like, what does sports performance look like, and what is REDS. Because if they have no idea, they're not going to be able to guide their athletes appropriately. And since they're kind of, the people who are seeing the athletes every single day, they're the ones who are going to pick up on these things. And these are also the people who the athletes really trust and they follow their recommendations, right? So in the most ideal world, they should be the people who are kind of at, the foundational level, kind of conveying this information. Even if it's not super duper specific, that's okay. If they can kind of convey that you need to be fueling appropriately, that you need to be recovering appropriately, et cetera, that would be really helpful. And then ideally, those athletic trainers and coaches should know signs and symptoms of REDS so that if it does come up, they know when to tell an athlete, like, hey, maybe you should go in and see your doctor and be checked out. Now, one thing we've already touched on is a lot of healthcare providers actually don't know that this exists, right? And that's also a big challenge. And I think that as healthcare providers, all of us, regardless of specialty, should at least be aware that this is a thing. And even if you just know that, then you can refer to somebody who does know enough about it to be able to do the whole workup and treatment plan. So, like you said, you're probably not going to be seeing a lot of these patients. But if you happen to come into contact with one, it's nice for you to know that this is a thing that exists out there and know who to refer to so that they can actually get the care that they need.
Is there a time that one should sort of pull the trigger and refer to a specialist in REDS?
I would say if it feels like something that you maybe have heard something about from a medium like this, or you've seen something about it online or at a conference, briefly about it. If it is something that you're worried about, but you don't feel comfortable with the workup, I would consider referring to a sports medicine specialist who treats REDS, or getting them to, there are kind of popping up all over the country, female athlete programs. So many cities now actually have clinics that focus on treating REDS. And the reason that is because it requires such a big multidisciplinary team. So our role as a sports medicine provider is to help with management of the athlete presents with acute injuries. We're really helpful in working up that acute injury, giving them, restrictions for sport, helping progress them back as they're improving. But we also rely, and we can also start with the kind of laboratory and general workup that's required for REDS to help understand who else might need to be involved in this team. So when we're thinking about treatment, then we start to go down the route of, well, a sports dietitian is paramount in treatment of this because they understand how to build a dietary regimen that matches that athlete's activity level and can meet their demands and help them to gain weight, say, or to at least match their energy needs so that we can get them out of this low energy availability. So we will often refer to sports dietitian specifically. If we assess that this athlete has, mental health concerns or behavioral health concerns, we're linked in with multiple behavioral health providers, both within our institution and in our community that we can help to set them up with. And then kind of going forward, if they have pelvic floor dysfunction or menstrual irregularities that are persistent or very severe, we may get our OBGYN colleagues involved, especially in an adolescent athlete. For more of our master's athletes, so our female athletes that are over 35 years old, bone health might be a bigger concern. So if we have low bone mineral density and we need help from our endocrinology colleagues or bone health colleagues, and we'll get them referred. So it really is kind of getting a big team involved. So if you feel uncomfortable as, a primary care provider or even a sports medicine provider who doesn't see this a lot, try to find someone in your area who treats this. Reach out to people kind of on the national stage. They may have friends or colleagues in your town that they can help refer you to, but definitely don't leave this kind of unaddressed. So make sure you're getting your patients linked in with someone who can really address the whole situation and get everyone involved that's required.
Yeah. The other thing too, that I want to add is that a lot of these services, so like mental health counseling or dietitians, a lot of them nowadays at least do a lot of telemedicine visits. So sometimes I get the question of like, okay, you're at WashU in St. Louis, you have all these resources, awesome for you. But what happens if you're in this like more rural community and you don't have access to all these specialists? What do you do? A lot of them can be provided via telemedicine, which is actually really helpful. Obviously, it doesn't work for like a musculoskeletal evaluation because it's really hard to do a physical exam on someone through a computer screen. But for some of the things, yeah, you can treat them virtually. So if you're in a community where you maybe don't have access to all of these specialists, there still are kind of networks out there that can help see patients virtually. So I think that's important for people to know too.
In the perfect workup for a patient, I know everyone's different, but if you were to receive a referral of a patient, are there things that you all like to have had done already prior to that patient coming to your clinic?
Good question. Not really. And that's because honestly, there are a lot of labs and things that other people aren't aware of that we tend to check. So I'm fine with just kind of starting from scratch and doing it myself, because I don't want people to get poked multiple times for labs and things like that. So I have a whole lab panel that I tend to check kind of generally for patients in whom I suspect REDS. And then depending on kind of what else they're there for, we may add on certain things. We may get like a DEXA scan to check their bone density. But honestly, a lot of the time it's easier if I just kind of do it myself anyway.
Fair enough. That's good. And then lastly, I appreciate everyone's time so much. But I think, nowadays social media is just everywhere. And it's funny if you kind of criticize or critique social media, you sometimes have to get on social media to do that. And I was just wondering about everyone's thoughts on the impact of social media on female athletes' mental health.
Yeah. Big question. Absolutely. And, we are on social media. So, we'll start with that. And one of the reasons for that was there's a lot of misinformation on social media. And we also know that people are accessing social media, good, for good and for maybe not so good, that it's happening. And so our adolescents, our youth especially, are on social media. And so I think one thing with our goal was to really, if you're on there, there's a resource that maybe we can point people to that's going to have evidence-based information on it that isn't that misinformation. Now, in general, though, we are seeing the impact of social media, particularly if it's, I think overused or becomes something that is adolescents or anybody's main point of connection. We see a lot of mental health concerns that can come up with that. It doesn't replace human interaction. It doesn't replace, friendship. It can't replicate those things. And we know, the dangers of, especially our younger populations getting tricked into things and falling for things. There's a lot of, it's harder to monitor it. It's harder for parents to monitor who their adolescents are communicating with. But also we know there's issues with body image that can come up, and once again, someone might say, oh, well, this girl is, eating this much and looks like this and is performing it this way based on what her Instagram says, or her TikTok or this or that. And first of all, we don't know if it's accurate. And there's this innate comparison that happens when we're seeing these images constantly of this is what is normal. This is what I should look like. This is what, a runner should look like, or this type of athlete should look like. And so I think we definitely see the comparison piece. There can be bullying that happens. There is some studies that show that especially those higher level athletes can tend to compare themselves with other high level athletes. And it also can exacerbate pre-existing medical conditions, even just the scrolling itself. If you're someone struggling with anxiety or even ADD, ADHD, there is that overstimulation can start to impact things from that perspective and can impact sleep in a negative way. I've talked to a lot of adolescents that are on their screens a lot before bed or on social media. And so it can contribute to things. And so I think, it's not the recommendation can't be to say, never go on it ever.
Right.
But really counseling on, it can be a tool and it can be a connection with some of your friends, but really knowing how, kind of trying to spot that of, is this actually causing detrimental effects? And we know that generally there are detrimental effects coming from it in our society, especially for our youth. And so I think it's something really important to think about and consider, even though I think a lot of us don't really know what to do with it, because it's even, it wasn't as big when we were younger. It was kind of just starting. And so, thinking about that, I think is really important, both for parents, coaches, healthcare providers. We can't ignore it.
Absolutely.
Ken, one of the things I will add too is, Sarah mentioned, we're on social media. We post a lot of evidence-based medicine. I know you're on social media. There are a lot of other physicians, healthcare providers, whomever, who are on social media and are posting some really good info. But the unfortunate thing is that, for every medical professional on social media, there are like a million more like influencers out there, right? And they can post whatever they want, and they have all this time to post. Whereas, we're all in clinic all day. So it's not like we're on social media all the time. So I think that because of all of that, their voices are kind of inherently louder than ours because there's so much out there.
Yeah.
So, I think if you are someone who is looking to social media for specific recommendations when it comes to healthcare or sports performance or whatever it may be, just try to find some reputable people. So it's not hard to see in people's profiles what their credentials are. If they have real credentials and they're posting, real research articles and things that kind of make sense, awesome. If they don't have credentials or they're trying to kind of exaggerate what their credentials are, that's a big red flag. And I tell people that all the time, and I think it's really important to think about.
It's wonderful. Yeah. Thank you. Dr. Randazzo, I didn't know if you wanted to add anything as well.
From a social media standpoint, I think just to echo a lot of, what they've talked about already, we know that it was studied in the, collegiate athlete level for females, that's just simply identifying, like as a female athlete alone, increases your anxiety and depression and kind of lower well-being. And, part of the impact of that is being on social media, having that upward social comparison, in addition to all the other pressures that you have. So when we're talking to our athletes about, maybe mitigating risk or kind of trying to improve your healthy relationship with social media, we encourage, active participation on social media. So don't just scroll kind of aimlessly when you're just kind of consuming what other people are doing and not really interacting and trying to create some connection. And then we also talk about other things like setting time limits, deleting apps temporarily or permanently so that you can have a break from them and walk away. And then I like to talk with my athletes about really paying attention to how you feel when you're scrolling. So if you feel like you've been on for a while, take a pause, kind of reflect on how your body's feeling. Is your chest really tight? Are you feeling more anxious? Does your head feel strained? Those are all signs that, you need to put the apps down. You need to go outside, go talk to somebody, in your family, call your friend, go play with your pet, go do something else. So try to, give yourself some cues for, like, I think I've had enough time on the app for today. I need to put this down and go do something else with my time and try to, clear my head. So those are some of the things that I would discuss with them.
Excellent. Those are all great insights. Thank you all for that. And we can find you on social media at Stronger Medicine, which is an awesome name. I love that because it's her inside that. And then I was just curious, what inspired you all to go ahead and start this, especially collectively, which is pretty cool.
Yeah, I'm happy to start. So, one of the things we were talking about is there just isn't enough good information out there on social media. There's a lot more that isn't evidence-based. And that's one of the things that really is kind of a big pet peeve of ours, is seeing all this misinformation out there that then is getting to our patients. So we collectively decided that we wanted to create an account where we could put out some good information on, health, sports performance, life in the medical field, et cetera. But one of the challenges is that when you're posting on social media, in order to get that kind of visibility, you need to obviously post regularly. And all of us are very busy clinicians, which really was one of the driving factors in deciding that we wanted to do this collectively instead of individually, because then we could kind of share that load. Because, I'm already working a full-time job and I have a family and I do sports coverage and, we're all kind of in that boat where we're super busy and I cannot post to social media every single day. But as a group, we can, and we kind of all share similar, opinions in terms of treating female athletes. So I think that it made sense to us to kind of come together and do this as one rather than 3 individual units.
I totally agree. I feel like we're all really passionate about getting this information out to the general public. So that seemed like a really good way to start sharing this information. And when we go out into our own community here, we are all in the St. Louis area. We've talked with local high school students or female athletes training, in a conditioning program over the summer. And the feedback that we always get is, I really wish I had this information sooner. Or we'll talk to parents and they'll say, man, I wish I knew this when I was growing up. So from our standpoint, it feels really urgent to get this information out that's high quality and evidence-based so that people can maybe recognize these symptom patterns or make a change to improve their health if they see even one tip or trick or, know when to reach out to a clinic like ours. So that's another thing that really drove this decision as well.
Yeah, and I think the other thing too that's really nice is obviously, Elena and I have similar background training. We actually both went to the same medical school. We both did the same fellowship. But Sara has a little bit of a different background, which I think provides a unique perspective. So she's really good at the lifestyle medicine piece and kind of providing some additional viewpoints when it comes to all of that. And I think really combining all of that together is what gets us the best information for our patients. I mean, clinically, that's what we do, right? We all work together. And so I send patients to Sara and vice versa. So I think that kind of collectively putting our thoughts together and then getting them out there is what helps people the most.
Sara, any final thoughts?
Yeah. I think the only other thing I would add is that I think a lot of resources for athletes or a lot of discussion with athletes or even what they're looking for is how do I perform better? And what we're trying to do is increase goals or make goals more inclusive to also include how do I feel less anxiety with performance? How do I think about how my performance now and my health now and my strength now impact my ability to have babies in 10 years or my ability to play pickleball for fun or golf when I'm 80. And so we're trying to expand resources to think, about how your performance matters, but also your mental health while you're doing it and what's driving you, and your friendships matter and the ways you're nourishing your body impact you now and in the long term. And so I think that's the other piece with the social media side of things and with our clinic and the work that we do is really trying to kind of expand the vision for what it means to be a healthy athlete and a well-performing athlete. There's just a lot of things that go into that. And we want you to do well in your races or in your sport or whatever that is, but really helping actually empower athletes, patients to know, actually these other things are going to impact your performance too. And it matters how you're feeling while you're performing just as much as how you're performing.
That is great. That's a great place to end it as well. Thank you all for such amazing information and your time today.
Thank you.
Yeah, thank you so much
for having us.